Hello, everybody, and welcome. Thank you for joining today's webinar, Breaking Down Barriers, How Exercise Professionals Can Gain Recognition in Clinical Settings. My name is Francis Narek, and I'll be your facilitator for this session. Despite the overwhelming evidence that exercise and physical activity is essential to disease prevention, chronic disease management, and overall well-being, formal pathways for integrating exercise professionals into healthcare teams remain inconsistent. Today's conversation will explore those gaps and why they persist, and more importantly, what you can do about it. Our panelists will be providing a few insights. One is the regulatory professional barriers that limit integration of exercise professionals into healthcare environments, how to establish credibility with healthcare providers through evidence-based practice, communication, and professional registration, and then practical strategies for building trust, navigating referral systems, and demonstrating value through patient-centered outcomes. We have an outstanding panel today with experience in healthcare policy, clinical exercise physiology, and certification leadership. They'll bring a unique perspective on how exercise professionals can elevate their role within the broader healthcare ecosystem. And so I'd love to be able to invite our panelists to describe who they are. And as a bit of a housekeeping, we ask your questions in the Q&A chat bot, and I will answer those at the end of the panel. Without any further ado, I'll start with Lori. You can provide a brief introduction to yourself.
Well, thank you, Francis, and thanks. It's wonderful to be here on the panel today. I'm Laurie Witzel. I'm National Vice President of Policy Research for the American Heart Association, where I spend a lot of time translating science and evidence into impactful public policy. But I also have the honor of serving as Senior Advisor to the Physical Activity Alliance. And I'll look forward to telling you more today about the work we're doing and the great collaboration we have with all of our board organizations, including the work that you're doing, the important work you're doing with CREP.
Wonderful. Jamal.
Hello, everyone. I'm Jamal Ozmek. I'm a clinical associate professor at the University of Illinois at Chicago, where I created and served as the director of our cardiac rehab program, which was housed within our faculty practice within our university campus. So I have some background in not only the education, preparation of clinical exercise physiologists, but also managing clinical spaces and programs where CEPs work.
Well, Dr. Scott Hurley.
Hi, my name is Scott Hurley. It's really an honor to be here today. I am a general internist primary care physician in the VA Pittsburgh healthcare system and an associate professor of medicine at the University of Pittsburgh School of Medicine. I've been at the VA Pittsburgh healthcare system for about 17 years. And for the last 4.5 years, I've had the honor of serving as the chief of the Division of Whole Health and the clinical director of our Whole Health program. Whole Health is VA's approach to lifestyle medicine that really looks to change the focus of healthcare from being on diseases to the factors that lead to disease and to better support veterans in their journeys to health and wellness.
Wonderful. So this is a phenomenal panel. And so let's start with Lori. And I guess with the first question, and it's going to be a very easy question for you, is what is the biggest barrier for preventing exercise professionals from being fully integrated in healthcare systems? And kind of what your thoughts are there.
Well, thanks, Francis. Actually, I think it's a pretty big question. There's a lot there, but I think first and foremost, the way our health system is currently, structured, that it's qualified healthcare professionals are the ones who can bill for services, and and right now under definition, so a qualified healthcare professional is a person who is qualified by education, training, licensure, and facility privileging to perform a professional service. They perform professional services within their scope of practice and report out on those services. And so qualified exercise professionals are not considered in healthcare system regulation to be, the person who can bill for services, but they can work within a team environment and be a really important part of the team, providing a critical service that is incredibly evidence-based, where even though they won't be billing directly, they can be part of the team that's delivering the service. And also, so within a healthcare system, a physician practice, a affordable care organization, or they can also be positioned in community-based programs, teaching evidence-based programs with community organizations that are positioned to bill payers or get compensated so that they're actually employed by the organization. So there are a number of ways we can work around the current regulation and infrastructure, the way our health system is set up, and we'll talk more about that today. But I think payment is kind of the one big barrier that we all talk about. And we'll talk about other things today in terms of continuing education and professional development that kind of sets you up to work and interact with the health system.
Any other thoughts on that for Scott and Jamal?
I think many of the answers to today's questions will ultimately come down to reimbursement. And that is certainly the case, because typically with exercise professionals, at least in clinical settings, they're placed into the cost center and not necessarily the revenue generating professionals. So in order to be able to do that, we do have to achieve that qualified healthcare professional status. And once that is accomplished, I think we'll see some big changes.
Okay. Next question for you all is, are healthcare systems truly beginning to treat exercise and physical activity as a preventive intervention, or is it really largely positioned as disease management? Maybe let's start with Scott first, and then we'll transition to Lori.
Thank you, Francis. What I've really seen is really a start of a change in the perception of how healthcare is delivered, from being focused primarily on diseases, and I think to one that's more focused on the factors that lead to disease. And what I see with primary care is a lot of frustrations with how healthcare is delivered by primarily focusing on giving medications and sheets of paper and not really truly supporting the patients that are being taken care of. And I think by only giving a medication, and I'm a general internist who prescribes lots of medications, I think by only giving medication, we're really just putting, a patch on a leaking wall, where we could actually be addressing the underlying causes, which for so many chronic diseases in our country that we've struggled to really control and adequately address, it comes down to, lack of physical activity, sedentariness, and poor nutrition.
Lori, I think maybe that's the question to you, is like, when you're thinking about this perspective, like the clinic to community linkage or kind of CMS or Medicare's innovation models, what are your thoughts on other kind of the way things are kind of the way the environment's changing, kind of what your thoughts are on the clinic to community or the CMS innovation?
I think it's all of the above, Francis. I think accountable care organizations, value-based healthcare is where this is front and center, where health systems, clinicians, and payers are incentivized to keep people out of healthcare, out of the healthcare utilization, healthier, get, focused on prevention. So our current fee-for-service model, of course, doesn't have those kinds of incentives, but we're shifting, and it's a slow shift. It's like, at the same time, this administration, this CMS is really focused on changing the paradigm. So CMS is looking at regulation first to see if there's opportunity to pay for prevention in addition to chronic disease management. At the same time, if we don't have the regulation, we haven't shown cost savings, return on investment yet, maybe we need to go over to the innovation center of CMS. And as you said, test these clinic to community linkages, these opportunities to refer patients into community-based organizations with evidence-based programs, to show, and it has to be this, it has to show cost effectiveness, it has to show positive or at least neutral neutral cost effectiveness, but positive health outcomes. And we can then make the case over and see it. Then, you show proof of concept, you can take it over to CMS and pay for it. And then, as we know, what CMS does, generally the payer community follows. And so I think we've got a really nice foundation here of some exciting models coming out right now from CMMI to test chronic disease prevention and treatment that must include either physical activity or nutrition. And then also, using digital health wearables to empower patients to understand and manage their health more, working hand in hand with their clinicians. So I think that's exciting on the innovation side. And I think over on the CMS side, they're also looking at ways to be more aggressive about paying for prevention and treatment. So I think we're on the cusp of some really great stuff. And we want to make sure that physical activity exercise is well positioned in all of those conversations.
Lori, I can add one of the things that I've noticed as a physician that until recently, I wasn't quite aware of how broad the literature was for exercise on positive health outcomes. And I think everyone knows that exercise is good for you, but I really wasn't aware of the magnitude of the impact that exercise has on many chronic conditions. And what I've seen is that physicians who have trained at facilities that embrace exercise as medicine or have strong partnerships with the exercise as medicine concept tend to incorporate that more into their practice. And the example I always give is exercise oncology, where I can see a big difference in the care that's being provided to patients at facilities that incorporate resistance training into treatment of prostate cancer, where you can negate a lot of the muscle loss and bone loss with anti-hormonal therapy that's provided through exercise, but yet only a small fraction of patients who get that treatment with prostate cancer actually are recommended the importance of that, which just fascinates me. And the gulf between the exercise science literature and the clinical medicine world is just blows my mind. And I can tell you that in medical schools, physicians or the medical students are not getting taught this.
Thanks for saying that, Scott. That is such an important point. And I think we have to continue to make that case and somehow figure how we get more integrated into, if not the medical school curriculum, certainly in professional education, continuing education. We've got to make this case. And it's so profound. We did a systematic review last year that showed that we actually have a return on investment in prescribing exercise interventions of about $1.15 to $1.70 for every dollar spent. And so payers need to hear that. But as you said, clinicians need to understand the benefits of exercise, and we need to bring that home. There's some really great research happening right now, funded by NIH, that's doing the molecular mapping for the impact of physical activity on the whole body system. And it's such exciting work. And you and Ashley, who's helping to lead that, calls physical activity one of the most potent interventions we can do within healthcare. And I'd like to kind of broadcast that as much as we can across the clinician and healthcare ecosystem.
I think the next, kind of going to Jamal, I think looking at from your experience and how the relationship of exercise professionals and clinical medicine have emerged over the years, how are you as a not only as a clinician but then also as an educator, how are you preparing your students for this kind of this change from disease management to prevention, and maybe a combination of both? How are you preparing them?
Yeah, I think first, whenever we talk about prevention, we have to consider, is it primary prevention or secondary prevention? And I think what we've largely talked about now is primary prevention. And without a doubt, there has to be an investment in that realm. But ironically, in the secondary prevention realm, specifically cardiac rehab, pulmonary rehab, there's only a certain set of diagnoses that qualifies a patient to get into those services. And as Scott pointed out, there's data upon data, and the literature is just piled up showing the benefits of exercise across various chronic diseases. And we pull our hair out whenever we see someone who doesn't have the very specific diagnosis, but is right there at the edge, but they can't take advantage of our services. And so what we end up doing, not only at our program, but across other cardiac rehab programs, pulmonary rehab programs, who have phase 3 cardiac rehab, where it's essentially out of pocket. And that's a big barrier for a lot of patients. They have to pay out of their pocket to essentially have a gym membership in the facility where clinicians are supervising exercise amongst those who have chronic diseases. That is one way in which we can extend that secondary prevention to patients that don't necessarily qualify through insurance to have coverage for those nearly exact same exercise interventions. So I think there's got to be a broader appreciation across various secondary prevention programs to extend those services out to said patients. And hopefully, with the accumulation of data that shows the economic benefit of doing that, then we can continue to expand that diagnosis list to include multiple different disorders or conditions. Diabetes is a fantastic example. We have diabetes prevention programs, diabetes self-management, education, and support programs that are covered by insurance, but those are largely educational. And there's a missed opportunity to incorporate an exercise intervention within those structured and covered programs. And so from the educational side of things, these are discussions that we have with our students to, one, for them to not only understand and appreciate the regulations that dictate who gets to have access to those services, but talk about creative ways in which they would be able to utilize their knowledge base, their skills, to interact with physicians and other programs to be able to expand out services during the time at which they may not be accessible via insurance. And there has to be a lot of creativity that goes along with that. And with creativity, you have to have a deep, deep understanding of a lot of the barriers and limitations that exist so that you can really approach that head on.
Maybe we can expand it a little bit more in that point. I think when we've had lots of discussions at the different conferences, and like one of them was like, there's more than enough research says exercise and physical activity works. So it's going beyond just kind of the efficacy data. And the discussion's really been more like the economic case or the business case of structured exercise therapy programs. And I know, Laura, you brought that up, but is that the piece that's kind of missing now? Is like, do we have enough economic evidence that says exercise and physical activity has an ROI of X? Kind of what are your thoughts on that?
Yeah, well, we did do that initial study. It was with 8 chronic conditions, including cancer and, some others that we've mentioned today: depression, anxiety, fall risk, osteoarthritis, etc. But I think we can always continue. We have to continue to expand on those economic data. That's really important as we talk to regulatory agencies. But to Jamal's point, I mean, we are advocating for exactly what he said. With CMS under the cardiac rehab regulation, can they expand that to other conditions? We have this infrastructure already set up, so can we take advantage of that? That would be, I think, a huge step forward. At the same time, I think we have to open up opportunities for that clinic to community referral too, if we want to meet people where they are. So the other thing too is, can we develop that or offer that cardiac rehab infrastructure virtually? Through telehealth, et cetera. And thankfully, we have the ability to do that now for the next 2 years. And then hopefully that will get extended by Congress more permanently. But we do have to meet people where they are. And it may be that we could also offer the opportunity for, like we said, evidence-based programs in the community, home-based, offerings. And so that's why the Innovation Center is so important, because we can continue to look at other models, delivery models as well. But I think we've got this primary opportunity right in front of us to expand an existing infrastructure that is more than evidence-based. And as far as heart disease, it's got a Class 1A recommendation. So cardiac rehabilitation really is transformational. And yes, so to your point, Francis, we've got to do a few things. We've got to make the economic case to expand that. We've got to test other innovation models for additional. It should be like a menu of offerings that we offer a patient when their clinician talks to them about being more physically active. So, can you attend a program in your community, or is there a home-based program you can do on a digital platform that, is inspiring for you? So lots of different ways we can deliver. And I think, right now we've got some regulatory agencies looking at this really closely.
Francis, I wanted to add 2 comments to what Jamal said earlier. Primary versus secondary prevention. I think, secondary prevention, you're going to show the return on investment much quicker. But and that is good in many ways. But I think we're really missing the boat by not focusing on primary prevention. the true answer to combating chronic diseases by not having them develop in the first place and being proactive and implementing those measures. The second thing I wanted to mention is I think there are lots of programs out there, like you mentioned, are largely educational, but what I've seen with patients is they need lifelong support. Health and wellness is a lifelong journey. And if you give somebody a 16-week, 12-week session, they learn the material. Oftentimes, what happens is it dies there. And I've seen this with rehab therapy many times, physical therapy. Patients get better with physical therapy. They're given a sheet of paper. That paper usually goes and sits on their desk or gets thrown away, and then they're being referred back for the same problem 3 months later. But what if we could actually transition them to exercise and to maintain those benefits and identify when setbacks are occurring earlier?
That's another really important model, Scott, which has been done in some systems, but you're absolutely right. If we could scale that nationally, it would be so helpful.
And the problem with primary prevention is it just takes so long to show a financial return on.
Mm-hmm.
Maybe that's a really good transition. I'm sorry, Jamal, I cut you off, Max, please.
No, I was just going to make a quick comment. Yeah, Scott, I think you can really relate to this, but whenever patients start taking medicine or medication and whatever that ailment has been cured, they don't need to take that medication anymore. Unfortunately, some people will do this for blood pressure medications, lipid medications, etc. But I think that has transitioned over to exercise is medicine or exercise as medicine, where if they go to these programs that have a defined set period, 12 weeks, 16 weeks, etc., they finish it up. Is like, great, I'm done with my medicine. I'm going to revert back to what I did before, being physically inactive. So I think putting that deep emphasis on what are you doing for the rest of your life with exercise, physical activity has to be discussed by practitioners.
Awesome. I'd say let's pivot a little bit, but kind of extending our current discussions. I think one of the questions that I have is, what is a successful structure of the referral? What does it look like? What does a successful referral look like? And I'm wondering, Scott, if you can describe your work at the VA and kind of the vet fit and how that works and kind of the positive benefits that you're looking for and kind of how that works now.
Sure, I'd be happy to. Thank you very much. So I'm very fortunate that I work for a healthcare system that actually supports the delivery of preventative services and promotion of health, like the VA, or like exercise, and that's the VA. And so we've been fortunate that we have the system of whole health in the VA, which is really meant to support veterans in their journeys to health and wellness. And we've built our program here at the Pittsburgh VA centered around exercise. So we have 6 qualified exercise professionals on our team who are delivering our services. We have a variety of referrals from different sources. We've tried to reduce barriers for patients getting referred by letting them self-refer. We get many referrals from primary care physicians, rehab medicine providers, specialists, even behavioral health providers, because of the benefits of exercise on mental health issues. And the way we do the back and forth communication is if the patient self-referred, we put the consult in for them. And then our team of the qualified exercise professionals evaluates the patient, see if there's any contraindications from their standpoint by chart review. And then we send a note to the provider asking for their concurrence. I've noticed that many physicians are get a strong negative feeling when they hear the term clearance, and a lot of it derives from their experiences with preoperative evaluations being asked to clear patients of surgical risk. And I found that the term concurrence to not having any contraindications to exercising is a much better way to do that. We're fortunate that we have a unified healthcare record too, where all the information is entered into the medical record, so they can see the exercise sessions that are being done. The qualified exercise professionals enter blood pressures and heart rates in, which also helps the provider. They can communicate issues from the the patients that are brought up when they're exercising and really help and serve as an extension for the physicians. But I think the best thing that serves the closing the loop with communication is actually the patient themselves, who goes back to the referring provider and tells them about their great experiences, and also shows, improvement in weight, improvement in all other health metrics.
One of my favorite stories, I think, Scott, that you described too, is one of your patients, and with one of the veterans. I think one of the ones you described to me, I wonder if you could talk about that story at a very high level. It's just like the use of was the decrease in substance abuse disorder, the substance abuse that they were doing, but because of exercise and physical activity. And it's kind of it was an interesting story. I think that if you would be able to kind of share about that.
I'd be happy to share it. And actually, this veteran is sharing her story with the entire VA community. She has put her story out in the form of a video, which is just in the process of being released. But in the year prior to joining our program, she had actually had 10 intensive care unit admissions from alcohol use. And I just commend her being able to share this story with other veterans. And she had gone through our substance abuse program multiple times without success. But what she found in Whole Health in Pittsburgh was a team of people that cared about her, and also a group of veterans who cared about her. And she felt that she could not drink because she'd be letting them down. And I think she even says it in the video. She can't drink because she needs to exercise. And the first time I met her, she had come up to me and said, I see you here a lot. Who are you? And I identified myself, and she said, would you mind if I give you a hug? And I said, sure. I thought, a little bit unusual, but she said, I just wanted to thank you because this program and these opportunities that you and your team have created have kept me from drinking and have made me much healthier. She couldn't walk up 3 flights of stairs, or actually 3 steps, not 3 flights, but 3 steps before. And now she's able to do so without any difficulty.
I just love that story. It's just one of the most powerful stories. Just like really kind of shows the patient champion perspective of it. I'm going to pivot a little bit to Lori and kind of, can you speak to kind of the incentives of accountable care organizations or CMS to really support and sustain kind of referrals? Kind of what your thoughts are there, talking about incentives.
Yeah, so that's another really important structural system change thing we need to work on. To make all this happen, we have to align financial incentives. Clinicians, health systems, payers have to be incentivized to incorporate physical activity, exercise as medicine models into their clinical workflow. And in order to do that, you need quality, clinical quality measures. And CMS is driving those right now, especially digital. They want to see all measures digital in the ecosystem. So, and I know a lot of clinicians and many are, stakeholders or partners are like, oh, not more measures, but I think we need a core set of really impactful measures around this. We are working, when I say the American Heart Association has some funding to work on a clinical quality measure for physical activity assessment and referral. We are working on contracts with health systems now to be able to collect and validate the data, create a reliable, quality measure that we can share with CMS, hopefully in 2027 or 2028. But that work is moving really quickly. CMS is really trying to drive toward aligning financial incentives around both prevention and treatment of chronic disease. So we're feeling the urgency. And so I feel like, it's a space we need to be in if we want to make this all a reality, and work with a number of folks who can, we want a broad expert advisory group to help us build this out.
Let me go to Jamal on this one. It's kind of when we're thinking about multidisciplinary care teams, how can a qualified exercise professional or clinical exercise physiologist make themselves an invaluable member of the team?
Yeah, great question, Francis. I think first the qualified exercise professional needs to believe that they are the expert in exercise assessments, exercise interventions when working across various populations. And so with that, their knowledge, their skills, their abilities, their training is prepare them to be able to look at a patient's medical records, interpret it, and understand how they would be able to utilize different assessments, how to modify an exercise prescription relative to the comorbidities that a patient may have. In addition to that, they're in a situation where they're working with these patients 2 to 3 times per week over 3 months. And that is extremely valuable because physicians, unfortunately, are only allotted 15, 30 minutes at best every 6 months, 1 year, to be able to go over a whole host of different conditions, concerns, medications. And during that time, it's very difficult to have some really meaningful follow-up unless it's someone who has pretty severe conditions. And so what we do with our multidisciplinary team here at UIC is that we have regular conversations with our physicians, cardiologists, nurses, pharmacists about specific patients who require additional oversight. So whenever they come in for cardiac rehab, we'll have various questions that we must kind of follow up with or answer to make sure that a recent medication change has been effective, or if a patient has been effectively letting off fluid, if they had any type of situation where they were withholding fluid. And so this is a really great opportunity for the qualified exercise professionals to keep physicians in the loop and to stop anything from essentially going further down the wrong way for these patients and ensuring that they're able to make a quick recovery and really get back to a stable state. And it really starts with, again, the qualified exercise professional having confidence that they are the expert in exercise and that they are a valued member of that multidisciplinary team.
Great. The next one, I do want to pivot again. I think this is when we're thinking about things like what's on the horizon for formalized referral frameworks and doing healthcare and providers and exercise professionals. I think one of the things that, Laura, you've talked about is access and elevate. Can you talk about what those are and why they matter? You're muted, by the way.
Helps if I'm on mute. So we've been, I was just putting into the chat, so now I don't have to do that. This is great. We've been actively communicating with CMS and CMMI on these exciting innovation models that have come out. I think there's tremendous opportunity for Elevate. CMMI is going to fund 30 applicants, 15 in 2026 and 15 in 2027, to address both chronic disease prevention and treatment. And nutrition or physical activity must be included in all applications. So we are out there right now talking to applicants we know are interested in this, trying to generate as many applications we can that include physical activity and physical activity models. That's why I say it's a really exciting time. And we have heard of a lot of interest. So that is all, really, really good news. Access is, there's a lot of buzz about the access model too. And I think this is where the agency is really trying to incentivize the use of wearables and digital health technology in addressing chronic disease treatment, especially things like cardiokidney metabolic disease and so forth. So I think we've heard a lot of folks interested in this as well. CMS recently released more information about the model. And we've heard that there's tremendous payer interest in access. So I think we can provide the links to both in the chat. But if you are in a health system and you think well positioned for applying for these, I would say the request for applications is out for access, and we have heard that for Elevate, the NOFO will be out by end of February, early March. So it should be any time.
Next question, I think, is with the emerging areas in technology and how digital health technologies are reshaping kind of referral pathways. What are your thoughts on that, Lori, and maybe Scott? when we're thinking about the digital health technology, how is that affecting kind of how these referrals are happening?
Yeah, so I think we're all trying to solve for interoperability. Traditionally, health systems have not communicated well with community-based organizations. Health systems do not like to release patient information out into the beyond their system. And so there have been intermediaries that have been playing the role of receiving the referral from the health system and then communicating it by fax or text to the community-based organization. But there is federal regulation called TEFCA that is trying to work on this interoperability issue. And EHR vendors like Epic have been are really out front in this and trying to make it easier for health systems to communicate directly with community-based organizations. I think for a while, though, intermediaries will still play an important role, health information exchanges, community care hubs, et cetera. But if we can solve this for whether it's for social drivers of health, obesity treatment, healthy food prescription, or in our case, physical activity prescription, we solve it for one, we're going to solve it for all because it's a barrier that all of us are trying to work on. And interoperability is front and center, and I'm really hoping that we can keep figuring this out. There's a huge need, and we're advocating for it as much as we possibly can. I don't know if that
Scott?
helps answer your question.
Yeah, absolutely. Your thoughts, Scott?
I can add that I think one of the challenges in clinical medicine is the fact that many healthcare systems operate, with different electronic health records. There's been many calls for, a universal electronic health record. I practice in a system that has a universal health record, which makes accessing information much easier. I like to focus on the positives of technology and the fact that I think that you can use technology to increase the risk or the reach of the qualified exercise professional to get to patients who are more isolated through the use of apps, through the use of different platforms where you can deliver group exercise activity and instruction. I really think that that's, we're in that wave now where that aspect of technology, I think, has made it easier in many ways to deliver exercise. The challenge, I think, is then how do you document that? How do you communicate back to the healthcare systems when there's not always an easy pathway to submit that information?
I just mentioned, Francis, I put it in the chat, but we worked over the last couple of years to do a HL7 FIRE implementation guide for physical activity assessment, prescription referral, and feedback. To Scott's important point, like clinicians want to know what happened and did their patient follow through. So we are ready to work with any health system information technology team to help integrate this into their clinical workflow. It's out there in the public domain for anybody to use, and we really hope we'll have some uptake. Because one thing we know is if we can all be measuring this, so this is what the reason we went about this work is because we heard from clinician champions like, I want to do this in my health system, but I had to work for 2 or 3 years to set it up in our EHR. And we wanted to try to minimize that barrier by creating this implementation guide that would standardize this across the country. So we did get it done. So it's out there for the first version, standardized use. We're continuing to update it and bring it to a normative standard. But we want to make it as easy as possible, knowing, though, that this is a big investment for health systems to integrate this into their workflow and train their clinicians. This is not easy, and I've come to appreciate what a big lift and expensive lift this can be. So we're looking at other ways we can incentivize. And I think when payers start to pay for exercise prescription, then we're going to see maybe more of the floodgates open.
Laura, we'll come back to that. I think it would be very helpful for the audience to have an example of how we've started to implement that. I think the North Carolina Collaborative would be a good example. Like, here's kind of the work that you're talking about, and especially if folks are just very interested in getting involved and kind of figure out how to do that and get involved. We'll come back to that. But I think to Jamal, I think understanding kind of like where this virtual training and kind of virtual cardiac rehab are going. What are the knowledge, skills, and abilities that you think that a registered exercise professional will need to know kind of moving into the future? What do you need to know now? What are these should we be teaching the classrooms, things like that? What are your thoughts there?
Yeah, sure. I think a lot of us, particularly in the cardiac rehab world, but also in the education world, I've really been kind of sitting back to see what's going to happen with virtual cardiac rehab. I think I could maybe compare it to AI when we first heard about it, particularly me. I'm like, it's not going to catch on. No one's going to use it. And of course, we use it on a daily basis now, and it's just commonplace. And virtual cardiac rehab is, I think, very similar. The one strength that virtual cardiac rehab has is that multiple research studies and meta-analyses demonstrating a similar impact in fitness and health outcomes compared to traditional center-based cardiac rehab. So the evidence is there, it's effective. Now that we're starting to see a greater adoption and appreciation from the legislative side, I think this thing is going to stick around long term. It's not going to be going anywhere. And so I feel like universities and specifically exercise physiology programs should prepare their students to be effective as virtual exercise physiologists. And a lot of this has to come down to opportunities to practice utilizing virtual platforms to deliver exercise. A lot of universities or exercise programs might have adult physical fitness programs in their fitness center. It would be a great opportunity to play around and expand services for virtual exercise for some of those participants so that students would be able to get the skills to communicate virtually, be able to kind of work creatively when working with these patients and realizing they don't have any exercise equipment at home or any access to a gym. How are they going to get their heart rates up for cardio? How are they going to stress their skeletal muscle system to be able to elicit hypertrophy or strength gains? And it really comes down to enhancing their skills to think on their feet, their creativity, and really again, this doesn't have to be an older adult, but commonly we equate older adults not comfortable with technology or being able to follow instructions related to that. That's been dispelled, but certainly there are some individuals that might have challenges with that. So how do you effectively communicate what you want that patient to do without being able to physically touch them, and then make sure that they have the right form, they are performing the correct movement competencies? And so a lot of that is going to have to come down to some practical application and practice within some of those settings. In addition to having opportunities to observe cardiac rehab programs that do this type of intervention, and this will set them up for success for not only working in cardiac rehab programs, but there are a number of companies that are coming out with these types of services. So they'd be great candidates as professionals within those companies.
Wonderful. And I think maybe two more questions, and then we'll kind of go into the kind of open Q&A towards the end of the last 10 to 15 minutes. I think maybe, Lori, if you want to describe the projects that you're working on now, and in my mind would be the ones where how are you lowering their barrier from the referral side in the wonderful work that's happening now when you're going from the physician and kind of the how that's getting integrated in the electronic health records through to getting the referral to a program. Kind of can you give a kind of an example of that and kind of and why that's important?
Yeah, Francis, we knew that it would be really important to show proof of concept as we built up this implementation guide. Can we actually get a health system to be able to seamlessly refer either to a medical fitness center, into their cardiac rehab? Obviously, they can do that, but into community-based organizations. What does that look like? So we did pull together a collaborative in North Carolina with the health systems and the health IT teams in those health systems. The Epic, which is really North Carolina is unique in that Epic is the primary EHR vendor for almost all the health systems in North Carolina. And then the WISE, of course, you were there, Francis, with ACSM. The exercise professionals are well represented. In community-based organizations, the North Carolina Department of Health. We brought together a lot of stakeholders from the Physical Activity Alliance side to the health systems, to Epic also came on board. And so we had a lot of presentations to the group. We started to talk about what's involved, how might we pilot this to show proof of concept that could then be scaled nationally. And we've got everybody holding hands now, ready to jump. But it's really clear that we need investment, financial investment, to make this happen. You know, to my my increasing understanding of the cost of implementation for health systems. And I think the innovation models are going to help us. I hope the Elevate, especially Elevate, if we can get one or more health systems interested in applying from the collaborative, that's the kind of investment needed to get them, to get this integrated into their clinical workflow. So that's where we are right now. I hope to, continue to move all this forward. My dream, honestly, Francis, is that we would be able to, through our fundraising work, be able to start, like a grant program that would provide resources to health systems to get this integrated. And, if you have Epic, really involved and they're able to make this interoperability happen, then I think that's powerful because they're just such a big player in the space. But we want to do this across the board. So we did work with the Office of the National Coordinator to get physical activity assessment included into the U.S. core data standards. So those are the data standards that are required of all EHRs across the country, and they're tied to the federal interoperability rules. So we're hoping that, by 2028, or somewhere in there, we might be able to see physical activity as a required part of assessment as a required part of EHRs across certified EHR vendors in the country. So those are the kinds of things we're working on, hoping to show proof of concept, hoping to bring resources to this work. But it's great to see CMS really focused on this right now. That's going to help.
Awesome. I'm going to ask one more question before we get to the audience questions. I think one is, and if you can briefly describe it, is how can a registered exercise professional communicate their value to a healthcare team? I'm going to start with Scott. Is as a physician, what are you wanting to hear? Because you work with a ton of clinical exercise physiologists, what are you wanting to hear as a physician in showing that they're value to your team?
I think most physicians want to hear how the qualified exercise professional is improving the health and well-being of patients. And what are they doing to move the needle towards health from disease? I think they want to know what's being monitored when they're exercising and know that it's safe. I think from the provider standpoint, physicians and other healthcare providers, I think you have to assume that the baseline knowledge of, different exercise parameters is probably limited. So they want to leave that up to the qualified exercise professionals. But I think having a clear line of communication when injuries occur, when progress is made, and it just has to be a very brief summary, and not being told of every single little thing that happens when somebody is exercising. So there's the balance between delivering the big key bullet points and knowing what's important, and delivering too much information as well.
Or your perspective from a systems side?
Yeah, I would agree for Scott. I think credibility is just, first of all, continue your professional development, certify to the top of your ability, and demonstrate, as Scott said, your contribution to health, to the health outcomes of the people you're working with. That's going to be true to convince the physician or other, advanced care practice clinician you're working with, but also the payers, government agencies. If we want to, move it up to the systems level, systems change level, we've got to be able to show, you demonstrate the impact that you're having on patient outcomes. So I think it's, I think we've got a great opportunity here to make that case, but we can all work together to pull the information into a really concise and compelling narrative and message framework for all the change leaders and policymakers we're talking to.
Jamal, from a clinical exercise physiologist to the healthcare team, whether it's physical therapist or physician, like, what are your thoughts? What are some key things that you think about?
Yeah, and I completely echo what Scott and Lori has said. And to add on top of that, the exercise professional first needs to believe that they are a valued member of that healthcare team. Thinking back to my own personal experiences, first starting off as a student, seeing this time and time again with different other students, young professionals, I think there's a sense of intimidation when being in a clinical setting with physicians and nurses. And there may be this underlying feeling that they might not be qualified to be in that clinical setting. But everything that they've done in their training, both didactic and applied training, has prepared them to be successful exercise professionals. And one thing that I see that has worked well, with myself as well as our students, is the patient advocacy side. A lot of times when working with clinical populations, frail patients are not referred for exercise services because physicians believe that they would not be able to do it. And in those cases, we advocate for that patient. We let the physician know that we're able to modify the prescription and deliver the outcomes that will be meaningful not only for that patient, but also for the physician's experience with managing that patient. And with many of those individuals, our physicians come back and they thank us. And they're almost, in many cases, kind of in disbelief that this person previously was wheedled into their office. Now they're walking in, very comfortably into their office. And I think that really boosts the confidence of providers and boosts the trust in those exercise professionals to be able to work with those high risk patients.
Jamal, I always say that the patients are the best spokespeople, the best salesmen for exercise, because what's going to leave a lasting memory in the healthcare provider's mind is seeing the person who could barely walk, who was falling multiple times a day, who now is able to come in without a cane, without a walker, and is not falling. That's how you earn the trust of providers. It's hard though, because you got to get that initial, you got to get that initial connection, but it only takes one person, and then that, exponentially grows.
Wonderful. So 2 questions from the audience. I know, Lori, you answered one of them, but I'd love for you to answer it live. But let's start with the first one is from the audience is, are we benefiting from medicalization of exercise? There are a few instances where exercise is contraindicated and everyone can benefit. What are your thoughts there?
Yeah, so I am sensitive to that, that we don't want to over medicalize it, but I think that we need to look for every possible avenue to support people in physically active lifestyle. And so, part of it may be this formal referral, assessment referral process and healthcare delivery. But I think there's also the opportunity, kind of back to the primary, even primordial prevention work we're doing. Comprehensive school physical activity programs, programs at work that support movement and active work during the day, healthy active work during the day. Community-based programming, parks and recreational facilities, active transportation infrastructure, right? Like those are the primordial, important environmental systems changes we can work on as a community, physical activity community. But I do feel like this is one important route, and I don't know if it's medicalizing, but it is really offering a really important lifestyle behavior that can be transformational for health and well-being. And I think we owe it to patients, to what Scott said early on, to help clinicians understand why this can be such a potent intervention, and why we really do need to make it a standard of care.
Francis, can I add on to that? Because I think this is a really important concept. I hear a lot of frustration from my physician colleagues when the qualified exercise professional has to go back to them and say, is it okay for them to a patient to exercise? Because in the mind of physicians, everybody should be exercising unless you're having unstable angina, you have critical AS, there's very few contraindications to exercise. And so I think that is one of the biggest barriers to exercise, is when you have to go back to the provider and say, is it okay to exercise? Because it creates a lot of internal, they feel like they're checking a box from a liability standpoint. What I have found is that qualified exercise professionals are oftentimes doing a much more accurate assessment of whether it's safe to exercise or not. But you need that level of communication between the providers, so that if issues are developed, or if issues develop, or if issues are identified, that they can feel comfortable going to the provider and saying, is this patient still okay to exercise? Because what I find is that the qualified exercise professionals get more information out of the patients than the providers do, because they're limited in how much time they spend. I've heard physicians, response to qualified exercise professionals when they say, "Oh, the patient said that they get short of breath with exertion," and the provider will say, "Well, they didn't say that to me." And so just because they didn't say it, they might never have asked, is always my question. So, but that's one of my missions as a physician, is to really decrease the barriers to people safely exercising. If it increases the safety of exercise, I'm all for it. But from the physician standpoint, I think, a lot of times people think like, why do I need to say it's okay for this person to exercise? Everyone should be exercising.
Well, there's an interesting podcast on Freakonomics on the nudge behavior and how do you lower the barriers to whatever activity you're doing. And this falls right in line. The very last question I think we have is, are there any current reimbursement codes for physicians to use physical activity counseling? They're asking for their organization. They're trying to implement physical activity as a vital sign in their clinics. I know, Lori, you added some stuff into the chat, but I'd love for you to, at a high level, describe that and kind of point them in the right direction, and potentially to the PAA website and your CPT codes there.
Sure, yeah, thank you. So it was exciting to see in the last physician fee schedule in 2026, CMS did revise a CPT code to be able to pay for physical activity assessment. Now, that's not counseling, but that's assessment. So that was an exciting development, because I think that offers a great opportunity, a great foundation. So now we have the assessment. Now let's see if CMS can pay for the referral and the follow through. So that will be great, which they certainly do with cardiac rehab. So that's one CPT code you can use for billing. And then I provided the link to our CPT code table that summarizes all of the relevant codes that can be used for physical activity counseling intervention. And we have to work with AMA every year to have that reviewed and approved by AMA, since CPT codes are trademarked and copyrighted. We're in the process of doing the latest update there, but I did provide the link to that if that's helpful at all.
And Lori, I have a follow-up question, if that's okay, Francis.
Yeah, please.
What's I suppose, the minimum that you would have to do to be able to say that you've assessed physical activity? Is it the physical activity vital sign where you ask frequency, intensity, time, and that's it? Or is there something more involved?
They're not too specific, but I think the vital sign is a great way to kind of be really clear that you assessed for it. So, both aerobic and muscle strengthening activity, and hopefully then there was some conversation about follow through if needed. So I think documenting that is all you really need to do. And it's, you can do it twice a year, every 6 months, and definitely within the context of the annual wellness visit. And $20 to $25 for doing that assessment. So hopefully that's additional financial incentives for health systems, clinicians to integrate this into their workflow, clinical workflow, and just their typical visit. And the thing is too, you could do this you could set up with the assessment questions even before the visit, as people are coming into their visit, whether it's their online check-in, et cetera, but then have, the follow-up conversation during your time with them. Hope that helps.
It does a lot. Thank you.
Last minute here. I think maybe the question is just like, what is exciting in the horizon for the next 3 to 5 years? What are you looking at? And you're going, oh my gosh, this is getting me up and out of bed and ready to run. So let's start with Lori first, then Scott, and then Jamal.
Oh, I feel like there's at least buy-in right now for making this a standard of care, for positioning physical activity as an important lifestyle behavioral intervention for prevention and treatment. However, I will say that we need to continue to make this case. And, I think food as medicine is getting a lot of attention right now. And I just would advocate that we are alongside talking about both in the same breath. As a clinician, I think you would be talking to your patients about their eating and physical activity when you're talking to them. It's not exclusive. both are such important interventions. And I just want to hold those up as an important part of our treatment paradigm and prevention. But we have to, it's interesting. Physical activity, exercise sometimes seems hard. And so we have to continue to be able to, I think social media influencers are great in terms of getting people excited and creating a norm, social norm. So there's all kinds of ways we need to message and communicate and spread the word. But I'm excited for what's to come. I think we're going to see a day in 5 years where physical activity is paid for, intervention is paid for by the payers, and it's assessed by clinicians regularly, and patients are excited about following through.
I think we're going to see further steps towards exercise becoming part of healthcare. And, we use the food as medicine and the exercise as medicine both side by side, because I think they're so important components. And what I can start to see is a cultural change amongst some of my fellow physicians who are now thinking about when a patient comes in with high blood pressure or diabetes, instead of just giving the medication, they're also addressing the nutritional aspect, the exercise aspect. And I think that'll be furthered as, these pilots and collaborations between healthcare systems and exercise organizations that are able to provide the services are established, hopefully through the Maha Elevate movements, or the grants that are going to be awarded through that.
Paul?
Yeah, having some knowledge about what's happening with Clinical Exercise Physiology Association and ACSM efforts to pursue QHP, Qualified Healthcare Professional status. One thing that I'm excited about is seems like the pathway to achieving that is becoming clearer. Doesn't necessarily mean the work is going to get easier, but we have a strategy on how we would be able to achieve that. And we're making some great efforts collectively to do so. And my hopes one day is that rather than referring someone to cardiac rehab or pulmonary rehab, they're being referred to the exercise physiology department, and to be able to work specifically with an exercise physiologist at any level. And I think that's in our horizon. How far away that is, I can't tell you, but we are making progress forward. That's for sure.
Wonderful. We're 2 minutes over. I did see a message in the thread that the links that you provided, Lori, they can't see. I think they're getting sent to the panelists only. So what I'll do is I've made some screenshots. I will send it over to those who watch this webinar. I'll send it after. Apologies for that. We'll get those over to you as soon as we can after this as a follow-up. Thank you all. Thank you again for your time and your wonderful expertise. And this has been a wonderful discussion with you all. Thank you so much.
Thank you too.
Thank you, everyone.
Take care.